Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about breast cancer. When I left off last week, I got to the point where surgery had already been carried out. Now we're about to stage the cancer, and then we'll follow up with different type of treatment. And then let me give you the stat again as it relates to breast cancer according to the American Cancer Society. For both sexes, this year, 255,180 individuals would be diagnosed with breast cancer. 2,470 of them are male, 252,710 of them are women. As far as death rate is concerned, 41,070 individuals will die of breast cancer, 460 of them will be men, 4,610 of them will be women. Now, before I proceed, I just want to share that information with you. Before I started the series on breast cancer, if you recall, I did a series on prostate cancer. And if you recall that I spent a lot of time discussing the effect of obesity on the development of breast cancer and how the obese individual ought to be diagnosed, so on and so forth, and how that causes the cancer to be much more difficult to treat as well. And this morning, as I was getting ready to go to the hospital, I heard on the radio a big study come out of England talking about the effect of obesity on the causation of breast cancer, etc., etc. Now, I have not read the study. I do not know whether this is claimed to be something new or whatever. I just want you to be aware that you are way ahead of the game because I explained that to you a few weeks ago. And also, this particular idea came from me, and it is copyrighted in multiple books that I've written, including African American Health book, which I think is more than 20 years old, thereabout. It's not a new idea, but I'm not saying anything negative about the study. I'm not saying that anyone is taking my ideas or whatever. I have not read the study, but I want you to know it is not a new idea. In fact, you know it's not new because you go back, look at the shows that I did a few weeks ago. I explained that when when a man is obese, because of so much fat cell that he has on his body, and he has a lot of what's called cholesterol ring. All hormones, in order for them to be made, you need the first ring, which is the cholesterol ring, and you attach different chemical things to it to produce the hormone, in this case, the testosterone or / androgen. And then the level of that becomes very high because that particular individual who's obese has so much fat cell on board. Therefore, much more of those cholesterol rings are found in the circulation, and more of the male hormone is produced. Therefore, the gland get overstimulated by the testosterone / androgen, hence increasing the propensity of developing prostate cancer. And also, in order to treat the prostate cancer, it becomes much more difficult because the more androgen you're producing, the more you're growing the cancer cell, because the prostate cancer needs androgen to grow. That is why to this day we are either castrating men chemically, or they're still in some places doing it surgically to get rid of the testes that are producing the testosterone, the androgen. So this is nothing new. But I first came up with the idea years ago when I just started writing books, and this is one of close to 12 or more general idea and concept that I came up with that are being used all over the world to practice medicine. So I just want you to know the idea is fantastic, but it's not new, and I was the first one in the world to come up with it, and it's published and copyrighted under my name. I just wanted to clarify that in case you read about it this evening when you turn on your TV and your radio, etc. And you could go back and look at the shows that I did a few weeks ago, and I talked about that extensively. Now, staging of breast cancer. Let me go through that with you so that you have a good idea. Breast cancer has four stages, okay? You have stage 0, which is basically ductal carcinoma in situ, tubular carcinoma in situ, and Paget's disease of the nipple. That's stage 0. And of course, we treat that in a different fashion. Then we have stage 1. Stage 1 breast cancer is a breast cancer that is about 2 centimeters or less in dimension, with no lymph node metastases, neither local or distant. That's stage 1. Stage 2 is a breast cancer that is 2 centimeters and less than 5 centimeters and has metastasized to the lymph node or node in the same side of the diaphragm. That is to say, here it has not gone below the diaphragm. That is stage 2A. Then you have stage 2B, when the breast cancer is a tumor that is about between 2 and 5 centimeters, and there are nodes that found, and the tumor is malignant, and it is found in both sides of the diaphragm. It hasn't, and that's of course stage 2B. Then you have stage 3A breast cancer. There's multiple scenarios. It has already metastasized to different nodes. The tumor is greater than 2 centimeters, and it is the same side of the diaphragm, and 5 centimeters it has metastasized. Then you have stage 3B. The tumor is with direct extension of the chest wall with metastases to lymph node. That's 3B. Then you have stage 4 and so on. So that's the different stages of breast cancer. Now that the cancer has been staged, then you have to make a decision to go about how you treat. Stage 1, almost 100% of the time, I mean stage 0, as I meant to say, 100% of the time, is done surgically, and that's the end of the story, and you just observe the patient every 6 months or annually with physical exam of the breast and mammography, and as well as ultrasound, etc. And then if the cancer is stage 1, and it is 2 centimeters, then it's going to be removed either via lumpectomy or mastectomy based on the surgeon's recommendation and the woman's choice, etc. Okay, and when that is done, if it's done by lumpectomy, the surgeon is going to be node dissection. They're going to dissect node under the axilla on the side where the tumor was to make sure there's been no spread to those nodes. Okay, then if of course, based on the pathology report, that the cancer has already metastases to the node and the surgeon already knows that, then the recommendation will be made. You have to you have 2 choices. Either you do the lumpectomy and you do radiation therapy followed by chemotherapy, or sometimes the chemotherapy is done first followed by surgery and then radiation, etc. Then if you're talking about somebody who's already have stage 3 disease, then the choices are pretty obvious. You're going to remove the breast with breast reconstruction, and then this patient almost always wind up getting either chemotherapy before the surgery or immediately after the surgery, sometime a combination of radiation and chemo, etc. Then if cancer is already more advanced than that, then you're not talking about surgery, you're talking about just radiation and chemo to do the best you can to provide supportive care for the patient, and depending on the age of the woman in question, then you have to pay close attention to the ovaries, and these people always, no matter the stage, we're going to be screened via the folks who are involved in the genetics part of the hospital to do BRCA1, BRCA2, so on. As far as the doctor, the medical oncology is concerned, you're going to do estrogen receptor, progesterone receptor screening, and HER2 receptor screening. That is very crucial, because to really truly understand and comprehend the prognosis of this cancer, you really have to know the quality of the cancer, namely, is it estrogen positive or negative, progesterone positive or negative, or HER2 positive or negative. That is absolutely crucial, because now that you've done that, if you are talking about chemotherapy, then you really have to understand the age of the patient. That's crucial. If it's a younger woman and she happens to be estrogen negative, the treatment is quite completely, totally different. And I have the different lists here, or different type of chemotherapy protocol that we use, then depending on what we are dealing with. If we're dealing with someone, a woman who is estrogen positive, then of course clearly we're going to go with the most common protocol out there, which is Cytoxan, methotrexate, and 5-FU. Okay, that's for estrogen positive tumor, and that's the protocol that we're going to use. On the other hand, and of course, in terms of the extent of the disease, determine whether we treat for 6 months or 1 year. Okay. Now, if, on the other hand, you're dealing with someone who has estrogen negative, progesterone negative type tumor, then the protocol that is in use is Cytoxan, adriamycin, and 5-FU. Again, the cycle, the number of cycles that is given is based on the extent of the disease, the stage of the disease. If it's a stage 1 disease that's require chemo, then of course it's almost always 6 months. Okay, if it is stage 3 or 2B, then we sometimes almost always go for a year. This is how it is done, and the cycle is a 28-day cycle that we use. And of course, there are a whole host of other medications out there that I use in cancer that are more advanced. You could use you have protocol that has vincristine, cisplatin, etoposide, mitomycin, vinblastine, and etc. that you include in this different protocol. Okay. Now, some folks also use Taxol. Now, for women who have HER2 positive or HER2 really accepting is used. If you have HER2 positive, nowadays we use Herceptin. Now, what you have to understand, Herceptin is super expensive. When I mean super expensive, costs more than, I think I wrote it down here somewhere, and I don't want to misquote it, but it's more than, yeah, I have it right here. It's $5,900 a month, close to $71,000 a month. Now, we treat now for a year, but before we know what to do, when it was first discovered that Herceptin was good to treat HER2 cancer, nobody would tell us how many years to treat for. Some of us, myself included, treated women for 3, 4, 5 years until because they waited for 5 years of experience for the powers to be to tell us who are not in the research business that 1 year was sufficient. Well, we were afraid to stop, because we were afraid that if we stop, the patient cancer may come back. So because of that, we kept treating. But I mean, you have to understand how expensive. It's $71,000 or thereabout per year. This is what this stuff costs. Lately, there's been some more. I believe the FDA is now in the process of approving some more drug that has to do with HER2 positivity, and I'm not very familiar with them. I have not used them. Therefore, I will not talk about them. But I'm aware that new things are being produced in the process of being approved by the FDA to treat HER2 positive tumor. Now, what you have to understand, let me explain to you the mechanism of estrogen positivity and also HER2 positivity. Estrogen is the fuel that makes the cancer grow. Okay? Estrogen, let me repeat that, is the fuel that makes the cancer grow. So therefore, as important as estrogen is to women, you can't be a woman without producing estrogen. That's part of the female anatomy. It's very, very, very important. However, once you have estrogen positivity, it means that the same estrogen that is so important to the female physiology is also feeding the cancer to make it grow. That being the case, then, we take advantage of that. We take advantage of that by using medication that block the ability of the estrogen to overstimulate the breast. I'm talking about tamoxifen, I'm talking about letrozole, anastrozole. Those medications are out there, so we're using them for up to 5 years in women that are estrogen positive. Even after we finish giving them chemo, we keep them on this medication to block the ability of estrogen to keep overstimulating the tissue of the breast. That's very important. We take advantage of that. However, for women who have estrogen negative tumor, it makes it these tumors are much more aggressive to treat because we can't block the estrogen. There's stuff we cannot do. And the same thing applies when you have HER2 positivity. The HER2 positivity, we take advantage of that. We take advantage of the HER2 positivity to use Herceptin to block that. That then prevents that HER2 positivity from overstimulating the breast. So we take advantage of that. So you think, well, estrogen positivity, it is a problem, yes, but we take advantage of that. But if you have HER2 negativity, you have estrogen negativity, our hands are tied. We are only depending on chemo and radiation. And chemo and radiation quite frequently is not enough to help us. That's what makes estrogen negative tumor much more challenging and much more difficult to treat. The same thing applies to HER2 positivity. While the HER2 positivity, it has a negativity attached to it, but we take advantage of that by blocking it. We could use so when these tissues are taken out and sent to the pathology lab, the pathologists are well suited to do all these tests so that to know what quality of tissue cancer we're talking about. And then we take advantage through our knowledge and experience of the field. We know what medication to use to block what. And that's how we pretty much treat breast cancer, which is a very, very problematic. All you have, 1 out of every 8 women in this country is at risk of developing breast cancer, and the same statistic across the world. And of course, if the woman has family members who have breast cancer, a mother, a sister, a maternal aunt, and a father who's had, let's say, prostate cancer, a mother who's had ovarian cancer, all these things, there's a crossover. So these women are very high risk. So we begin to screen them at an early age because we know they're at very high risk. And then for the younger women that have very dense breasts, we do MRI of the breast, which is much more accurate than ultrasound and sonogram to try to pick up cancer that are very early in the breast. And then we also watch out for ovarian cancer in these women as well. For that matter, so you have to understand, anybody who has one breast cancer has a 50% higher chance of having a second cancer than someone who's never had cancer. And I'm a perfect example because I've had 3 separate cancers at 3 separate types of cancer at 3 separate times in my lifetime. So it's very, very important that one knows exactly your background, where you come from, what kind of work you did, what sort of toxin you were exposed to. In my case, I have no clue because I'm an orphan. My mother died when I was 7. My dad died when I was 9. I have no clue what these people had or was about to have. I don't know. What I know is the fact that I was so darn poor, and I got exposed to so many toxins, trying to survive, work in so many horrible environments, inhale all kind of junk, and I have almost 100% sure that the cancers that I've had, all are due to stuff that I was exposed to, stuff that I ate, stuff that I inhaled, all kind of stuff. I remember working downtown Manhattan at the Manhattan Industrial Center for a company that I don't have to name them. I was operating a machine that was emitting dust. There was dust all over the place, and there were no masks. We're talking about in early '60s. There was no such thing as us having masks. As a result of that, I wind up with having surgery for my nose at the old polyclinic hospital. I wind up having surgery for my throat at the old polyclinic hospital, which also almost killed me. I mean, this is kind of stuff that I've been through. Okay, I mean, it is hell on earth, the stuff that I've been through, but somehow I managed to survive, and I'm here talking to you on television, a fully qualified, well-renowned physician. You might have to say this myself. You say, well, how did this happen? Well, listen, you go and ask God. How did all the stuff, the horrible stuff I had to. But I never complained. I never once have I complained to God, why me? Why did you do this to me? I never said a thing. I just do what I had to do. I even work in a sweatshop in Long Island City. That, unfortunately, that's the only job I actually left. After 2.5 days, I couldn't take it anymore. I couldn't deal with the stench. This is the first time I actually quit a job because the conditions are right here in New York City. It was so horrible. So actually, that's the first job I actually quit, is the job pushing that cart on 34th Street without being able to see the cars in front of me or on my side. Multiple times, taxis almost knocked me over. After a couple of weeks, I said, no way, I don't need that. I'm gone. So all that kind of stuff, I'm sure, contributed to me having had cancer at 3 separate times. It's quite possible that I would have gotten it genetically as well, because maybe my folks were predisposed to have it. I don't know, because they die early. I have no clue. Suffice it to say, when you have health, be you a woman, a man, don't take it for granted. Don't take it for granted. Take good care of yourself. When you have symptoms in your breast, don't self-diagnose yourself. Go to the doctor. Explain your symptom to the doctor so that he or she can do the right thing to try to help you, to help save your life. Because if you wait too long, by the time you get to the doctors, we are not God. We just do the best we can. If you present to us with a stage 0 breast cancer, you have a good chance we could cure you. If you present to us with stage 1 breast cancer, there's a good chance we could cure you. I have cured multiple patients with stage 1, stage 2 breast cancer in the 44 years that I've been practicing. Because either they came to me early, or the way I practice, I pay close attention to them, make sure they get the mammogram, make sure they get the pap smears, make sure they do this, make sure they do that, and I watch. I keep track on them. Make sure it's get done, because that's just the way it is. If you have cancer, it is diagnosed early, you have a good chance of beating it. Some cancer, no matter what, it's hard for us to help you. But we'll talk about these cancers as I continue to talk about cancer during a series of the shows. So breast cancer is a curable disease, absolutely curable disease if picked up early. And the woman can play a major role in self-examining her breast herself, especially when she's having her period. If a few days before the period, when the breast is very engorged, during the period, or a couple of days after, because the engorgement will allow her to be able to fill a lump in the breast that is more pronounced. It's best to actually do it in front of a mirror in the bathroom. Why? Because if you have a lump, and you may not be able to fill it, but you will see a retraction. And the retraction, something is wrong. There shouldn't be a retraction in the tissue. That ought to be talked to a physician about. If you see discharges coming out of your nipple, that's not normal. It's never normal. And you're not breastfeeding. That's definitely not normal. It could be a serious endocrine problem, or it could be something else. Don't self-diagnose yourself. Go to the physician. I know that there's a healthcare issue. Many folks don't have healthcare. Many folks are on Medicaid. That there's a struggle. You have the people in Washington, D.C. that's supposed to be taking care of these things. Most of them, they have political power. They have political knowledge, but they have no medical knowledge. They don't know what they're talking about. I'm here to tell you they don't have a clue. Many of them have never been to the bedside. Many of them have never seen what goes to a patient in a nursing home. It is brutal. This is brutal. I have treated patients in nursing home. I have provided medical care multiple times over the years for patients in nursing home, especially when I just started out trying to build a practice. So I know what's going on in there. It's not pleasant. So these people are trying to make decisions to try to save money, and yet there are folks that are going to be suffered. Some of them are going to lose their lives because politicians are making decisions that has nothing to do with helping them, but to score political points, some of them just for the sake of being reelected, etc. It is disgusting. As a bedside physician, I can tell you, it's no fun. And as somebody myself who's also been a patient, it's no fun being sick. Okay, so take care of the fact that you have your good health. Know your family history. I don't, but know your family history so that you could use that on your own behalf, so that when you go to the physician, they're asking you about what work are you doing, what condition you're exposed to, what's your mother's health history, what's your father's health history, what's your sister's health history. We're not doing that for being nosy. That's very important information. If you don't remember, go home and ask aunt, ask the uncle or older sibling or whatever, because we need that information to help us make decisions so that we can help you. So breast cancer is very common, as I just stated. Okay, it is a bad situation. Of all cancers, 32% of all breast cancers will be found in breast cancer in women. So it's very common. 1 out of 8 women will have breast cancer, and his or her lifetime. So it's a very bad situation. So that is really all that I have to say about breast cancer. Next week, I'll begin a series on another type of cancer. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.